This is NC Spin, an unrehearsed discussion on issues of interest to North Carolinians. Now, here is your moderator, Tom Campbell.
Welcome to this special edition of NC Spin. This week we're delighted to be at the North Carolina Academy of Family Physicians winter weekend at the Grove Park Inn in Asheville, North Carolina. Our program this week will discuss health care in our state. Joining me for this special show are 5 people with insights on health care. They include Peg O'Connell, Senior Advisor with the firm Fuquay Solutions, also a frequent panelist on NC Spin. Peg has more than 20 years of experience in legislative, public, regulatory, and governmental affairs, especially in the healthcare arena. Over on my far left is John Hood, President of the John Locke Foundation, also a regular NC Spin panelist. John writes columns for many newspapers across the state, has written several books, and has spoken in all 100 counties of North Carolina on public policy issues, including health care. Dr. Conrad Flick is a practicing family physician who served on both the state and national boards of family physicians and the North Carolina Healthcare Quality Alliance. He has great experience in dealing with Medicaid and legislative issues. Over on my near left is Don Bradley, Dr. Don Bradley, a Senior Vice President for Health Care and Chief Medical Officer at Blue Cross Blue Shield, a family practitioner. Dr. Bradley helps formulate programs, interventions, and information to help customers make informed choices and to keep health care affordable. And on my near right is Representative Nelson Dollar, the Senior Chairman of the Appropriations Committee for the House, Chair of the Health and Human Services Committee. Nelson is widely recognized as the most knowledgeable legislator on health care in our state. Welcome, panel. No public policy issue has been more widely cussed and discussed than the Affordable Care Act, frequently known as Obamacare. Hardly a week goes by without changes, accusations, and controversies. We can't talk about health care in North Carolina without talking a little bit about the Affordable Care Act. Don, I want to address the first question to you. Insurance Commissioner Wayne Goodwin said that prior to President Obama's announcement that he was going to allow these non-compliant policies for another year, Insurance Commissioner Goodwin said that you and Blue Cross and he and his department had been in some discussions on that very subject. Just exactly what was the reason for deciding to have these conversations with Wayne?
Well, we announced on November 14th that we were looking at options for our members who may not be able to keep their health insurance, the plan that they like. So we looked at those plans, decided that we really needed to present an option, and we did. And I think the big concern there for us was really to give our members, those that already have our grandfathered plans, an option.
Peg, one of the primary goals of ACA was that everybody had insurance, and yet when we got all the rules and regulations, we found out about all these mandated coverages that had to be like people our ages who had to have, for instance, maternity care, for Pete's sake.
Well, Tom, the Affordable Care Act is intended to provide broad coverage to the largest number of people, which is, as Don knows, is the basic rule of insurance: lots of people, large numbers. It also wanted to extend the types of coverage so that people wouldn't buy something that only would cover cancer and then be surprised that they didn't have...
I mean, what was the problem with that, if that's suited an individual policyholder?
Well, you know, because what happens is people may get cancer, but they also have many other things. And then if they're not covered, they end up in the emergency room. And we all, as other policyholders and taxpayers, end up paying for it. Or physicians write it off, the hospital writes it off. So people need to be covered for all the things they're going to get.
John, there were a lot of people that questioned the president's decision to extend these non-compliant policies, saying that it may have been a very political decision. What impact do you think that it will have, particularly for a lot of these congressional Democrats who are facing re-election in 2014? What impact is that going to have?
I think the intended impact was to help them. This was an entirely political decision. The elimination of the lower cost plans in the individual market was not an accident. It was not an unforeseen glitch. It was always part of the plan. In fact, the president called these plans substandard and no one should have them. Oh, and you should be able to keep them, which is incoherent. It's really a political argument. There was a lot of blowback. It's immediately unpopular to take people's health plans away. So it's an attempt to kick it past the November 2014 election cycle. I frankly don't think it helped very much, but it did make the economics of the insurance pools a little bit worse, which is surely not in the long-term interest of the Affordable Care Act's existence.
Nelson, North Carolina had several decisions that it needed to make regarding ACA. One of them was regarding health insurance exchanges. The legislature and the governor decided that we were going to opt for the federal exchange, even though former Governor Perdue had said she wanted to do the state-federal. Do you think that if we had opted for a state or a state-federal, there may have been more people signing up? And do you think it was still the right thing to do to go with the federal exchange?
Well, you would hope if North Carolina did it, we could certainly do it better than the federal government. But there was really no state and federal. It's really federal or state, because the way we looked at it, federal government was going to be running by their rules. They were going to be hiring the people. We just felt like let them take ownership of it if they want to have an exchange.
I suspect after the rollout, you were probably pretty happy that you didn't have that mess on your hands.
We have enough problems with IT without having the exchange.
NC Spin will return after these messages.
Fishing isn't just part of my job, it's my life. It's a part of who I am and how I was raised in eastern North Carolina. It's how I put food on the table for my family. It's hard work, but I love what I do. There's something special about knowing that my long, hard days help feed friends, neighbors, and people in North Carolina. It might not be glamorous, but fishing is my life.
You trust your family physician to care for you and your family. We treasure that trust and are committed to providing the best care possible for all North Carolinians. It's time for Medicaid reform, but not without input from North Carolina's family physicians. Medicaid reform will impact health care for all of us. Tell state leaders you want your physician involved. We need Medicaid reform that's good for North Carolina. To sign our petition of support, visit rnchealthcare.com.
Started back in the 60s, Medicaid was intended to provide health care to the poor and those disabled. North Carolina currently has about 1.7 million people enrolled in Medicaid. This program costs over $13 billion a year, over which the state pays about $3.5 billion. Nelson, I want to start with you and begin this discussion along the lines of the legislature's decision back in January not to expand Medicaid rolls. We're told that up to 500,000 people could have been included. The feds said they were going to cover 100% of the cost initially, and then they were going to scale it down to 90% over a period of time. Tell us what went into the decision-making in the legislature as to why not to expand Medicaid.
Well, the law simply says that the governor would have to come to the legislature should he want permission to expand. What we were looking at is an enrollment system that was hundreds of millions of dollars behind schedule and over cost. The provider payment system, which has been a wreck for us the last 6 months, which we knew going into it. A department that frankly needs to be reformed. DMA that runs the Medicaid program is simply not up to the task right now. And with Medicaid reform coming, we just felt we could not increase that program by a full third, 500,000 people, without confidence that we could deliver a quality program.
You still think it was the right decision?
It was absolutely the right decision for the
Do you ever see a time when the legislature might change that?
Well, I think depending on how things develop with the ACA, how Medicaid reform develops, it is certainly an issue that can be revisited at any time by the General Assembly.
Well, I think putting that many people into a system all at one time is fraught with difficulty when there aren't enough primary care physicians in this country now. But the cost shifting is a reality. I mean, the cost of providing care in an outpatient setting versus in a hospital emergency room or otherwise is astronomical in the overall scheme of what we're trying to do and what we're trying to save.
The bottom line on Medicaid is it is in the entire country, it's a headache. It's a fiscal headache for states, for the federal government. The federal government can't afford the promise that it made, and it's a very strange promise. We're going to add somewhat less poor people to Medicaid and pay 100%, and then 90% forever, but poorer people will pay 60%. I mean, it's just not a believable set of formulas. No one could really take this seriously, which is why, again, I think it'll be dramatically rewritten before too long.
Well, I think in North Carolina, the problem has been people have assumed all these shortfalls were the fault of providers, physicians, hospitals, and that simply hadn't been the case. We've actually been controlling cost as regards to providers and the services that are out there. The problem has been mismanagement in the department itself, having to pay back the federal government for mistakes that were made, miscalculating the federal participation in the program, which cost the state hundreds of millions of more dollars. So really the problem has been more in the management of the program and not the provision of care in North Carolina.
It's also easy PR to say Medicaid is broken and we don't want to do anything about it, so let's give it to a private company to run. And in recent hearings, I've heard Representative Dollar say brilliantly, we have the tools in North Carolina to change what seems to be broken. But largely, it's not care providing. It's not the fact that people are going to the wrong types of providers. It's an inability, until recently, to be able to forecast what Medicaid's going to cost us down the road. And now I think the budget for Medicaid and the budget for the state is much more structurally sound so that we won't get these bad surprises.
But you talk about the problem in this country is we've got to decide as a society that health care is a right or is more, because we have socialist programs. We take care of our people. Tom was up here talking about firefighters. Our firefighting is a socialist program because that's important. Police, military, these are things as a country we've decided it's important to protect our citizens from these things.
The problem that we have in North Carolina right now is more with the division itself. Its inability to forecast. It's all these tens of millions of dollars which were off book, service definitions that cost the state hundreds of millions of dollars. Those have been the problems that we've been working on fixing. And of course, commercial managed care company would not be able to address that. We have to address that. We need to get the foundation in North Carolina correct at the state government level and then build on top of it.
All right, I want to get in.
I think we have something that we can learn, though. We have a program, a multi-payer initiative now called the MAPCP, where we've got Medicaid, Medicare, and Blue Cross Blue Shield patients working collaboratively in the state to really look at how care management can really be done in rural counties. So I think a North Carolina solution is, and a collaborative solution is, one, being done now and tested and can be highly effective.
The regionalization is occurring in part because if you do statewide and you have several different plans, the plans will have to have substantial assets. They'd have to be major national players. They wanted to involve networks of providers, even the CCNC type organizations that might have some skill, but they don't have assets. They don't have assets that could be managing care at risk. So they're going to start with smaller areas where you might be able to pull that off.
So you think they'll phase it in?
Well, they're saying they're going to phase in this concept.
Okay.
And I think the governor ought to be, if he's not, he ought to be flexible about stating what his goals are, which is, I mean, North Carolina's got a high, even with reductions recently, we have a high-cost Medicaid program compared to most states.
We hope you're enjoying this special edition of NC Spin. We'll be back with more discussion on health care after these messages.
The cost of everything has gone up dramatically over the last 75 years. With one exception, keeping electricity affordable. That's the power of your co-op membership. Learn more at togetherwesave.com.
North Carolina's touchstone energy cooperatives, looking out for you. Join business, policy, and education leaders from across North Carolina at the 29th Annual Emerging Issues Forum on February 10th and 11th at the Raleigh Convention Center. Teachers in the Great Economic Debate will be a forum you don't want to miss. Register at emergingissues.org.
C-SPAN.
Governor McCrory, in April of this year, proposed a private managed care Medicaid reform in North Carolina. This was met with just not only dislike but hostility, particularly in the medical community. Why do we not like this private managed care idea?
Well, you know, I think there are two things going on. First of all, we have in North Carolina CCNC, Community Cares of North Carolina, which is acting in a care management role and doing a remarkable job. On the day the governor made his announcement, CCNC got a big prize in Washington handed out by Richard Burr. So they're a remarkable program and make a big difference. The other part is managed care companies aren't going to change the end result. They may, what managed care will do is give you a short-term budget solution. You'll know that you have to put $1 billion on the table for this year. Now next year it may be $5 billion. So I think the most important thing about Medicaid reform or redesign is first let's figure out how to budget.
Be able to protect the cost. CCNC has 14 regions across the state, more than 1,700 primary care practices. About 80% of our total Medicaid patients are included now in CCNC on a per member per month basis. They show peer review evaluations that claim they've saved the state hundreds of millions of dollars. You and your organization have said you don't trust these numbers. Tell us why.
Oh, it's not us. We have been citing the dispute that is very interesting and elaborate in the community that evaluates these kinds of health programs across the country. There's a lot of dispute about the numbers, the claims that were made, the counterclaims. It's going on and will continue to go on for years to come. Managed care is not some odd idea that North Carolina might try, but other states have dropped it. It's the way most Medicaid is delivered in most of the United States, and they're not dropping it. Most states do it in some form right now. They're going to continue to do it because they can't afford not to.
If I might interject there, a number of states have dropped it. You've had managed care companies leave various states like Wisconsin, Oklahoma, Kentucky, others. But I've looked at the numbers. I've had the General Assembly's physical research staff look at the numbers. And if you look at the projection, and these are actual claims, the medical claims themselves, between 2007 and the most recent fiscal year, we've had a savings of about $1.9 billion over what we would have had we done nothing. Now that is a combination of both rate reductions that the General Assembly has done, service reductions and modifications of the General Assembly, and then probably about half of it has been attributable to CCNC.
What do you think Medicaid reform will end up looking like in North Carolina? That's a biggie.
Well, I don't want to presuppose what the advisory group is going to come up with, since I'm a member of that advisory group, but I think that you'll see some very innovative things coming out of that group, and I think that you'll see a very innovative, unique to North Carolina solution to these issues, and I think that in the end it will be the provider community, the physicians, hospitals, long-term care people will come together and you'll see North Carolina moving forward in a very united way.
We don't know exactly, but it's going to have probably some regional components, some phasing components. CCNC is going to continue to be a major player in delivering Medicaid case management. There may be others. I don't see that there's anything wrong with that. Usually we don't like sole source, non-bid contracts to spend state dollars. Yeah. We're usually against that. I think we should in this case also always consider alternatives.
All right, Peg, what do you think Medicaid reform will look like?
Well, I can tell you it won't look like it was going to look 6 months ago, which is 3 companies sign up and everybody gets dumped into there. I think we will. North Carolina is unusual. We're very rural. We're very metropolitan. So the old-fashioned concepts of managed care where a big insurance and bargains with a hospital is just not going to happen.
So I hope we'll see 2 things. One is that, remember, we're taking care of patients, and that's the center of the process. And second, we need to have a system that pays for value rather than volume.
Conrad?
Well, I would agree. I think, it is up to the legislative body and the administration to say which direction we're taking, but the physicians in this state have been very engaged from the very beginning, and I think that's one of the reasons that CCNC is successful as it is, because unlike managed care that dictates to me in my office and far away, the people in CCNC are a phone call away and in my office if I need them, and they're part of the solution with me, working to care for the patients that I see every day, not far away.
The 2013 session of the General Assembly passed the Health Care Cost Reduction and Transparency Act. Governor McCrory said that patients and their doctors have been in the dark too long about what they pay for common procedures. The list of costs has now been published. Has this made any difference so far as transparency is concerned? Can you tell if it's doing anything to bring costs down?
It'd be premature to evaluate the second part of that question, Tom. It's clearly improved or will be improving transparency. We all know, we've all had personal experiences, and of course practitioners know more than the rest of us, about the wide disparity in prices for what appear to be similar services delivered in different parts of the state or different parts of the country. There's seemed to be very little rhyme or reason to pricing.
Yeah, and I'll go back to value. It's quality over cost, and I think that gets to be a tricky equation. We've been providing quality and cost data to our membership for years. In fact, we've now got it on a mobile app so that you can see not only the cost, because I would agree, it is not just cost, it's what's the quality. CMS is now standardizing through Prometheus software so that we can get a better look, get a more standardized look at what we're doing.
So you also have to think about, we are a state with, Don, correct me if I'm wrong, 103 acute care hospitals. So, and some of those are in Halifax and Perquimans and Pasquotank County. So it doesn't, if it costs $100 in the Pasquotank Hospital, who's going to go to someplace else? I mean, we have these community hospitals, so it's not going to change behavior in the way I think they thought it was.
Well, Nelson, I wanted to ask about that. One of the trends that we've seen most recently that's taking place in medical care is hospitals buying up other hospitals, hospitals buying up doctor practices and so forth like that. Are we going to get to a point where we only got 1 or 2 hospitals in North Carolina? And is that good for the patients? Is it good for medical care in North Carolina?
Well, I think there's a real question as to what the impact on quality will be. But there's no question that had been a trend before the Affordable Care Act. And I think that since adoption of the Affordable Care Act or the anticipation of that adoption, you've seen nothing but a speeding up of that process of greater consolidation in healthcare.
There are lots of unanswered questions, as we've all talked about on this subject, but one of the things that we seem to have with pretty good authority at this point is that there is no obvious correlation between cost and quality, that there are high-cost surgeries going on in supposedly high-profile hospitals where the outcomes are no better than lower-cost operations going on in other hospitals. So you're absolutely right. We have to take the cost and the outcome measures and put something together, because some of the highest profile, most prestigious treatment in the world, Mayo Clinic, etc., are not the most expensive.
NC Spin is brought to you in part by the North Carolina Farm Bureau. The Farm Bureau and Agriculture. We keep North Carolina growing.
It's true. Farming is different than it was 50 years ago. We know consumers have questions about how our food is grown today. North Carolina livestock farmers want you to know that they're using the most responsible and caring farming practices to feed our state.
NCAnimalag.com.
We now return to NC Spin.
When I was a boy, Mama took me to the doctor. And Dr. Acock says that'll be $20. And she reached in her pocketbook and handed him $20. I think that with the current climate, with what we're in with health care today, people know what their copay is, but do they have any idea in the world what the cost of the care they receive?
I would say in general they do not. We can work on that through procedures and, again, some of the information we're providing. And frankly, they don't care.
Our whole system, and we've talked about this many times, where you have a person who gets a service and a person who gives the service, completely disconnected from the person who's paying for the service. And the person who pays the person who's paying for the service is the employer. So the people who are using the stuff have no dog in the fight.
Right. People need to focus on their health and not be so focused on their health care. And that's the key. So it's prevention, it's wellness. People need to take ownership of their own lives.
I think that when somebody else is paying for it, and we're not talking about the private market and individuals who are bearing the cost, even if it's an employer system, they're bearing the cost. We're talking about government programs like Medicare and Medicaid. We should try to push as many financial incentives and personal incentives as possible to patients, but ultimately there's going to have to be some decision-making at the state and federal level, and I think you need to be doing some kind of per-enrollee system rather than fee-for-service. We simply can't afford Medicare and Medicaid fee-for-service.
I think I heard you say per member per month. Is that your answer?
That's correct.
Okay. Conrad.
Well, we simply can't afford health care in the future of this country, no matter how we do it, if we don't make a change, private market or public. I mean, it just doesn't, it's not working. And I think that's part of when I get the whole criticism of the ACA is, what's your other option? Somebody has to do something.
What's plan B?
Yeah,
exactly.
There's no plan B.
Don?
I think we've got the wrong terms. Currently it's fee for volume. It needs to be fee for value.
We want to thank our special panel for being with us on this special healthcare show, including John Hood, Don Bradley, Nelson Dollar, Conrad Flick, and Peg O'Connell. And we want to thank the North Carolina Academy of Family Physicians for hosting us at their winter retreat at the Grove Park Inn in Asheville. Next week, we return to our regular format with topics of interest to the people of North Carolina. And as we always say, until that time, stay informed and watch out for the spin.
Join us next week and get the spin on issues facing our state.